and welcome to the Healthcare CEO Show, where you'll find actionable insights on healthcare leadership from the best and brightest in the industry. I'm your host, Daniel Fernandez. Let's get a pulse. This season, we're taking a particular focus on the healthcare industry and the M&A space. And with me today, I have my guest, Doug Badertscher. He is a returning guest, so if you've been following the show for a while, remember back when Doug joined us back in the post-pandemic phase, and there was definitely a lot going on in the world. Since then, Doug has returned to the company that he's with today, Pain Specialists of America, and he's going to tell us a little bit about that. Doug, welcome to the show.
So thank you, Daniel. Happy to join you today. Yeah, so my career path takes turns as the healthcare space. When we talked last, I was the CEO of Pain Specialists of America, and shortly after that, I decided to go with National Spine and Pain, the largest platform in the sector, private equity owned. And in 14 states, we had 150 locations. And so that was a fun journey. But in the end, the company wasn't able to do a successful exit strategy. And so I served my time as an officer in my non-compete. And private equity companies called, and Pain Specialists of America's board called me and asked me if I'd consider coming back to Austin. So I commute back and forth every other week to Austin, and excited to do it and excited to be in the space.
Now, with somebody of your skill set, you have lots of opportunity. What drew you back to Pain Specialists of America?
Well, a couple of things. I took a year off, which I'd never done in my adult life. That journey was interesting. I played a lot of golf. I caught up on some travel with my wife. I had to sit on the sidelines in a non-compete, but I selectively talked to a lot of different people during that period of time with a target line to be back employed in the middle part of 24. I actually thought about exiting the healthcare space just because the challenges out there are tough. They're all the things that I've ever done in 20 years in my healthcare career. I use them and more today to navigate the changing times. And I actually thought I was going to go to work for a company called Good Vet, which was a roll-up of veterinary clinics. But in the end, I decided that my skills were best served back in the healthcare space. And I chose to come back to Pain Specialists of America because they went through a reset, meaning as a private equity-backed company, their private equity firm needed to recapitalize. They bought themselves back, and they reached out to me and said that they felt I was the best fit to come into their enterprise and help them forge their way forward in a busy space, in a changing space, in changing times. And I was honored to do that. And so that's what I was familiar with the space, familiar with the people, familiar with the private equity firm. And so it was an easy decision to reach a conclusion.
Now, you have a multi-specialty background. What about the pain management space? What are some of those challenges that come with this particular specialty, and maybe some of the opportunities as well?
So you're correct. I've been in several verticals, including orthopedics and spine, physical therapy and orthopedics, radiology, outpatient imaging, and interventional pain. And so with interventional pain, it's a subspecialty. You're up against this pure spine surgeons who are out there, neurosurgeons, and orthopedic practices that have pain as a subset of their own group practice. So the things that are exciting to me personally, and one of the reasons I chose to come back, that really gets my energy going, is the new physicians graduating out of programs today and coming into interventional pain. They're highly trained in minimally invasive surgery. And the inventions that are coming out and are out now, and several things coming down the pike, are going to allow people to get back to wellness quickly, having surgery in a minimally invasive way, which I believe is easier for the patient. Having had back surgery myself on a disc, half of the population has back problems. You need to get back on your feet, back to work. And I don't believe being on long-term medicine is the answer. Physical therapy can be the answer sometimes. Massage therapy can be the answer, but sometimes it requires a specialized care And the new things, the new technology that's out there is exciting. And also interventional pain, we're a hub and spoke model. So we have 3 surgery centers strategically located in Central Texas, the 4th underway now, so that we can get people back to treatment quickly, get them in and out efficiently at a lower cost margin by using an outpatient surgery setting.
You talked about the 3 ASCs. Do you have any operational strategies that have been effective in driving efficiency and producing high quality outcomes? Is there anything that you want to share about that?
Well, I think quality of patient care is priority one.
Okay.
You know, I share with my team all the time a puzzle that has 4 pieces to it. Number 1 puzzle is patient care. The number 1 puzzle piece, rather, is patient care. The number 2 puzzle piece is our people, our team that work for us. The 3rd piece we have to put together is our physician team. And so selection of physicians is so key and critical. There are differences in them, and how they treat patient is their choice. I don't get involved, nor does my leadership team, in how they treat a patient, or they're managing the staff and the other things around them. But if they're doing the right things, they're making the decisions that drive patient care and get patients back to work. As you know, the opioid epidemic in America and the fentanyl epidemic, you know, it's put its thumbprint, unfortunately, on pain, and sometimes tagged the industry in a bad way, in a bad light. That's not us. That's not what we do. Our guys are most of the times double boarded in anesthesia and double boarded in pain. And then we have our own training physicians that are highly trained to do minimally invasive spine surgery and other advanced techniques. And so when we hire young guys, we're able to put them in a surgical setting and actually grow them with us until their skill set allows them to fly on their own. And so I think that patient care speaks for itself, and the economics out the other side. So, you know, I shared with you the number 1 puzzle piece was patient care. The number 2 are the employees that we have and our staff and the people. Number 3 is physicians, and lastly is the profits. So if you focus on profits, your focus is ill-conceived. Now, that's not to minimize profits. Any physician out there practicing today, in any group practice, you have to watch the profits, but everything can't be about the profit. It has to be about patient care.
That's really good feedback because, I mean, you specifically have worked with multiple PE-backed companies over your career, and having to balance the needs of the firm with the needs of the organization can be challenging.
Well, Daniel, I think you make a point that I'd just like to interject. You know, there's a lot going on in Congress now, and a lot going on in people talking about and bad-mouthing really private equity, and that they're all for profit. You know, they're business people, but I've never had them in my career in over 20 years, and I've worked for 9 private equity firms. I've never had them ask me to change patient care for profit. Yes, they asked me to find ways to drive profit and creativity, and to have us not waste money on devices or other things, and to be conscious about compensation to both our physicians and our staff. But they've left those choices to management. And so, you know, for doctors that may be picking this up and listening, and I talk to plenty of them around the country that call me or ask me for advice, is private equity bad or good? It's neither bad or good. Your situation has to fit in what they're doing and what their mission is and what their goal is. And you have to decide when it's time to take chips off the table, and you have to decide the problems you face as an independent practitioner, if what you're doing and money you're spending, and how are you going to retire, and how are you spending time with your family today, and the challenges and managed care. How are you fighting managed care and competing? There's few practices out there today, and there are some that I can point to that don't need private equity money. They've built a ship that can fly on their own, but that's not the majority of practices today.
Right. We've seen and worked with a lot of private equity firms over the years, and a lot of them have moved to more of that founder-friendly customer service mindset, allowing for more autonomy. And lot less micromanaging. But like you said, obviously there is some level of profitability that must be ensured. Now, here's a good question for you. As you're scaling up, you have to try to balance company culture and employee satisfaction. Any tips or tricks to share?
Well, anytime you're integrating physician or physician practices, they all have a culture, and some have a lack of a culture, which is a culture to itself. So I think for me, the key to success is deciding what the culture is going to be and stating it clearly in writing, and then having some founder physicians and a chief medical officer that buy into what those mission statements are and mission critical. And so that whether it's an employee we're hiring or whether it's a physician that we're hiring, we introduce them to the culture day one, and we try to make sure that they're going to be a fit, and the Wild Wild West isn't going to exist, because physicians supervise our mid-level PAs and APPs out there in the marketplace, and if they're not culture conscious and they think it's just okay to use language or do things or cut the day short, then they're out of sight, out of mind, and we can't manage the culture. And so we do a couple of key things. I think we do them well. We have physician town hall meetings where we bring all the physicians in, mandated. We try to do it once a month, but no later than every 2 months. And we talk about a lot of things. We talk about compliance. We talk about patient care. We talk about culture, where culture maybe needs some little lift. We talk about economics. We talk about them personally, and we have a good time. We fellowship together so we can build family out of there. Then we do the same thing with our employees, where we have town hall meetings. In fact, this Thursday, I'm having an employee town hall meeting. We're doing it virtually. It's too complicated and costly and time consuming to close all the offices and bring them in. But I'm on with them for 45 minutes. They've sent questions in, and so I'll address their questions, and we'll have a Q&A, and we'll record it for those that, have family obligation. We are closing the offices early so they can do this on our time. But I think communication builds trust. And without trust, there is no communication. And the third part of that is you can't have a relationship if you don't have communication and trust. And so no matter what size you are as a practice, as a group, or even a family, you know yourself from dealing with friends and things, that when there's no communication, things break down. Well, the same is true in business. And so I'm conscious with my management and leadership staff that our word has to be our bond. We have to have truth has to be at the center place of everything we do, and we have to communicate out directly. And so, sometimes I'm communicating at night, 7, 8, 9 o'clock at night, sometimes on the weekend. And so, I had one of my practitioners' mother died today, so we've already sent flowers. I've already called her, and birthdays for the doctors, birthdays for the employees. They get gifts. They get a personal touch. And I just think it's important. Now, I have a staff around me that help. I can't remember everything, but I have a good executive team around me. They know what's important, and they deliver that to them so people feel a part of an organization. I think one of the bad things that I can't think of too many good things COVID did for us. In fact, I can't think of anything, but one of the bad things it did, it put us in isolation, and it created havoc in the healthcare space when we were wearing masks. We couldn't smile. We couldn't speak to people. And some of that has carried over. And so I'm trying to bring a spirit of community and communication and relationships back to the workplace. So we're talking with each other. We're laughing again. And it's been a challenge, but you have to plan to do it. You have to be purposeful about it in how you go about it.
I absolutely love that. And that is definitely going to contribute to a higher retention rate, which obviously everyone is focused on these days. But the other thing they're all focused on is the team that you don't yet have, especially when you're growing. Any challenges or things that have helped you guys in that?
So I'm kind of smiling here because I knew you'd get me somewhere, but the biggest challenge today is retention rate. So I could take the time to pull up all kind of charts and graphs and show you that it's not money that's keeping people. It is not.
Okay.
And so I came from a company that post-COVID was 50% retention rate. When I came here, they struggled with 50% retention rate as well. And so it was a fast tackle for me, a fast attack, where we put a SWOT plan in place of how we were going to attack retention rate. And first of all, some of the hires were wrong. No matter what amount of money, you may have been paying the market rate or above, but if you put the wrong person there, the money didn't matter because they were going to leave anyway, right? And then if you had the wrong managers at the center level managing those people and they didn't build a relationship, then there was going to be turnover. In fact, we just launched this week, as a matter of fact. We're doing a group study. You know I'm big on group studies, right?
Love it.
So we're doing the 5 love languages in the business place. So I've sent the book out to everyone. They have to read it. I'll do an online class with my senior leadership team. Then I'll do an online class with my center managers. And then we want to see it permeate down so that we're learning how to deal with people. And I think as Americans right now, I think TV news bites, sound bites, the newspaper, all of that has taught us to act in a way and talk in a way that can be divisive in a culture right now that needs a healing. And no, the workplace is not a social wellness environment, but guess what? We're giving patient care, and in the pain space, particularly for our staff, it can be a hard space, right? People need healing, and you just get worn down. And with everything else going around you, if you're not consciously aware of the words you're using and your attitude and trying to lift each other up, then we just have a combat zone, and it just doesn't work. And trust me, I've had to deal with a few combat zones in the workplace. So our retention is rising, but it's not at 75 or 80%. And one of the most costly things to us, and again, I want to repeat, it is not the economics, because we're paying people at the highest part of the wage scale, and we're barely bending the curve on retention right now. And part of that is on the worker themselves. Workers have a different way they want to work, right? We can't work at home and work in the healthcare space and work in a clinic. It just doesn't work. And you can't have Mondays and Fridays off all the time, because that's the new world in childcare, and we face that. And so those challenges are still being hammered out, and we'll get there. But everybody, hospitals, outpatient clinics, nursing home, retirement facilities, we're all faced with the same challenges, and it's expensive.
Yeah. Do you feel like we're in a different phase of healthcare now post-pandemic? I mean, so much has changed. And for instance,
well, not just as so much changed.
Mm-hmm.
The workplace changed, the environment changed, the cost of paying staff went up about 12 to 15%. But then we had an inflation on top of that compounded things and added 8 to 10% to the cost. And so the pressures, your first normal reaction, like if you have a car stopping in front of you, your reaction is to hit the brakes, right? Some cars have automatic braking systems and they start slowing down. In healthcare, when you do that, you hear quickly from your boss, we better cut staff. And the problem is when you start cutting staffing levels below a safe place, you have more burnout. And then you created a bigger problem. And then you don't have time to train people to get them in so that they can learn what they need to learn in an efficient environment. And then you have people coming in just wanting a paycheck, right? They never really wanted to learn. It's their pathway to a next job. So it's a vicious cycle. And then when we get somebody trained, think about this, then you got to worry about them getting picked off, because the job market is so tight that they can walk across town for $2 to $5 if you're not careful. So you have to keep your center managers, and everybody that's in leadership has to be in touch what's going on in your working community to lift the organization. And it's a full-time task, different than I've ever seen before. I don't know when it's going to, honestly, Daniel, I don't know when it's going to change back to what it was. Probably never is the answer, but it's not the answer that I want to read. So you can't go to old textbooks to get new answers. And I'm not sure the answers outside of the things I'm trying, I'm open to different things. But when you get a think tank together, like, well, we just want to have 4-day work weeks. Well, it's difficult. That's a great idea. I love the idea, but how do I make the economics work? Because I have patients and I have expenses. The other one is, we want to start at 9:30 and we want to quit at 3:30, a shorter day. And then sometimes you have people say, I want a longer day. We want to work 3 12s or 4 10s, and we do some of that. But we're trying to accommodate the need out there. But there's a psychology that's got to meet the workplace that just is different than it is today, than it was before.
Yeah. All of that, I would say that when the math's not mathing, that it's just not going to work. It sounds like when you're trying to do things like that, the math is just not mathing.
But you spend, two components. You used to put a great HR director in, and HR would pretty much function. Now you really have to pay attention to that as a CEO. You have to listen. You have to get out into the marketplace and sit down and ask them, because just a couple wrong people hired at different locations can really create a mess for you in the marketplace. And the second area you spend more time today is in cybersecurity and protecting yourself from all the other things that you would have never thought about before. And then, of course, you have regulatory compliance that just falls out my ears every day. So we spend a lot of time, energy, and money on things that ran on rails that you could count on before that. I'll call they were automatics. When I started in the business, we didn't have compliance. We didn't have computers. And now, you have EHRs and, they've gone through life cycle changes. We're probably on the third generation in the industry of EHR systems. And some of the regulations, you have a program out there that the government put in place for Medicare called MIPS, meaningful use. And, that's a whole process to manage. So, the challenge, we still have the best healthcare delivery in the world in the United States. You'll hear people go pro and con either way. I think we still have the best healthcare delivery system in the world in the U.S. In different places in America, it's different. There's different care given in different states and different regions. It's not all the same. But, it is consistently tougher to be competitive today and to maintain a competitive advantage. 10 years ago, you didn't spend the dollars on digital marketing that you do today. You spend, used to do yellow pages and maybe you put up billboards or you ran vans and you wrapped them with your name on it. But today you've got to be real strategic on how you place digital advertising. It's a big deal. But we actually can track the patient care out of there. But it still has to be good patient care. Because if you have bad patient care, they're not coming back. So, right. Everybody in every industry has challenges. I happen to just be familiar with the healthcare challenges that have happened. And maybe when you talk to people in manufacturing or the grocery store business post-COVID, they may be saying the same things I'm saying with different words. I don't really know. But I know as an operator, as a CEO, as a board member in this space, given private equity or no private equity, the challenges are uniquely different, and you just work at it day in and day out.
Yeah, you've touched on quite a few things. I remember buying those ads in the yellow pages and billboards and all those media buys back then. And I remember the introduction of digital everything, and now it was all measurable as opposed to just having this big old billboard inside of the highway. So it's definitely changed. One thing, and this is kind of the space we work in, one thing that hasn't changed is good messaging. And like you spoke about, good communication is always the most important thing, because if you have a really crappy message and you're trying to broadcast it out there, it's not going to land. So good messaging is still key. You talked about digital security or data security. That is another very big thing. That's actually the most recent addition to our team is we brought on a global data security expert on our team that's helping us with some new projects. So that is another concern for a lot of companies as well, just maintaining their data.
I think another thing that I would bring to light is, the management depth of people out there, they're just not everywhere. When I go to hire people with healthcare experience, it's varying levels of healthcare management experience. And in a fast-paced world today, while I am taking the time to mentor them, and some of my executives now have worked for me in 2 and 3 companies, so that's a blessing that they're willing to take on another challenge. But I really enjoy mentoring young executives, but you want to still get the best in class that you can. get in. And so I would encourage young people today to, get a degree in healthcare in college or public healthcare in college, and then get inside of a clinic and learn your trade and learn your skills, because there's a lot to know. You can't just know, you have to know people, you have to know recruiting,
Right.
you have to know revenue cycle management, you have to know purchasing, contracting, legal, compliance, Medicare, commercial insurance. So there's a lot of things that you have to know and know about, and that now you have to know. You have to be able to talk your way around IT, right? And the words and the lingo, the cloud, and all the other things that go with it are so much different. You really have to pause and educate yourself, particularly those of us that are over 55 that are out there managing, because the space is moving quick in technology, really quick in technology.
Yeah.
I would say I get 2 to 5 emails a day about somebody wanting to do AI inside the company, and whether it's scheduling patient appointments online, whether it's going through my coding and my claims, whether it's call center. We even looked at robots and voice robots that are answering the phone. And most of the time I laugh, but when you listen to some of these things, actually it's pretty clever and it's pretty cool, and it is cost reductive. I'm just, in COVID, I offshored for the first time on call answering. That was unique me, because I'm old school in a call center, but when you're taking 200,000 calls a month and you have call centers that are all inbound in COVID, and the people all tell you they're going to die, you have to do something. And so I'm not saying offshore is the answer for everyone, but I considered it out of necessity, and I found good. In the past 60 days, I have listened to people that it's just robots, AI answering the phone, and the voices are just like yours and mine. And they ask intuitive questions. It's not like when I call American Airlines and it's kind of choppy, and they point you right back. Can I send you a text message? Can I send you the web link? That's not what they're saying. They can actually walk a person right through to setting an appointment. I'm not ready to be there yet.
Right.
And I can tell you, I've walked into clinics in the past 6 months where they did away with the people doing check-in. You went to a kiosk and you stood in front of the kiosk with your face and you entered your name in, and it told you if you needed to give them money. It told you just be seated and that they'll come out and get you. So, I had different feelings when I was in those offices, but is that going to be the way of the future? I don't really know. When we have Amazon that can drop a package in your driveway overnight, one thing we have to, on the same day even, right? So what we have to learn in healthcare is, people want to be seen, particularly in my space in orthopedic, they want to be seen in 12 to 48 hours. And if you can't get them in, they're going someplace else. So you have to find ways to capture them. And so there's many, many things that are impacting the space, but technology is costly, but it will change the shape of things going forward. And I'm not prepared to say if it's for the good or not for the good. I don't know. Most of the time changes work for the good, but when you're old school, I've only been streaming my TV at home for the past 4 years. I don't have any cable boxes, but a lot of people still use a cable box, right?
Yeah. Yeah. You've talked a little bit about, all of the potentially upcoming changes. What sort of changes are you most excited about with Pain Specialists of America, maybe over the next year and a half?
Well, I'm excited about the new physicians who have joined us. Number one, the minds that they have. I'm excited about the new technology. We do SI fusion and we do some things that weren't there before. Pain guys were the guys that gave you an injection and moved you on the way. That's not what we do. So we do injections, and I've had injections myself. Maybe you have as well. And, it feels good. I can get back up and move the next day if your back went out or you hit a hip or a knee. I had a knee replaced. So, I understand the surgical part of the business. But what excites me is our ability to use the technology that's out there, use minimally invasive, get people back to work. I'll send you there's a testimonial we're doing. A friend of mine that lives in Louisiana was just down in his back. He couldn't, he rode his Harley and, he just couldn't walk anymore. He was in so much pain. I sent him to one of our people, and we did neuromodulation. We put a stem inside of him, and he's doing a radio thing for us right now. We'll have it. I'll send it to you. But it was life-changing for him. And so we do a lot of neuromodulation where people are actually able to get back to life by having the treatment of neuromodulation. And if you've studied it and looked at it, it's a cutting edge. And now there's neuromodulation for diabetic neuropathy. And so people that have really suffered have a way to get out of endless suffering. And isn't that what it's about? So the number of people that are really in pain, debilitating pain, whether they're work comp patients from work comp, or they've been in accidents, personal injury, or they're just weekend warriors in sports, or just aging, changes in your body. It's endless, the number of people that have pain. And we've all been taught, oh, take some Tylenol and go to bed. Well, sometimes that just doesn't fix it. Or how many times have you heard, well, let's get an x-ray. Let's send you to physical therapy for 16 weeks and you're still not well. Right. And so to live in pain, it's just not what's intended. You have to have a quality of life. You have to get back on your feet. You have to get back to work. So that's what we're about.
I literally, this podcast is so appropriately timed. I literally couldn't agree more. I have some herniated thoracic disc from a car accident from years ago. Eventually, right. Microdiscectomy, but I've been on pain meds for 4 straight days right now.
Yeah, so, you give me a chance, you come to Austin, I'll put you with one of my guys, and we'll get you back on your feet. One thing I want to touch on is telemedicine, right? Yeah. So telemedicine was really birthed during COVID. Everybody talked about it, but it fast-tracked. You can go back and study all the billions of dollars that was forced into telemedicine. So, and in pain, the interventional pain space had telemedicine and orthopedics. But think about, so we've stopped using telemedicine here. It just, we think that it's not that it's not good. I've used it myself with my primary care physician, particularly when I'm traveling or when I'm sick, and he gets on and he's able to order for me the meds that I need to get me through a common cold, or we talk through things. But if I have a musculoskeletal issue and I need to sit down in front of a person, telemedicine may be a nice way to feel comforted, but it's not probably the best way to treat a patient. Now, people are going to disagree with me on that, but you can see the telemedicine trends now. Everybody thought in COVID came out, it was the ride to the future, but it really hasn't panned out that way. Now, I've used some, even with our health insurance, we have physical therapy, telemedicine, so we have access. If we need to have a physical therapy treatment, there's an instructor that'll come right on and show you the exercise and work you through it. So that's a pretty cool feature. But imagine doing telemedicine with my dentist when I have a cavity, or my eye doctor when I can't see well. Right. And so it has its place. But I wanted to touch on that and have people understand that it's out there, it's still being used, but it'll be used for its own specific purposes.
But in bringing this to a close, this has been an amazing podcast. To the person listening to this, you've led multiple organizations, multi-specialty in the past. What advice would you give them today to help guide them in the future?
To the persons that are managing healthcare facilities?
They're in similar positions to you. They're listening to this podcast. You have a wealth of knowledge. What sort of advice would you give that person?
First of all, I tell them to stop and take a deep breath because they're in a high stress position, right? So the physicians themselves, they're concerned about what their future is. And when you're leading people who are concerned about their future, chaos can reign. And so number 2, I would say strategically build a business plan and involve them in it. Talk about whiteboard. What are our goals for a group of people? What are your goals individually? And interestingly enough, you're going to find in a group of physicians that their goals are uniquely different based on their age brackets and their lifestyles. And that's okay. So segment into what the goals are of different providers in your group, because everybody's uniquely different, right? And I just shared a visual in one of my town hall meetings about the difference between an axe and a razor blade. An axe can't cut your beard, but a razor blade can't cut a tree. And so, but they're both used for cutting. But the difference is we need them both in our lives for different things. So are the physicians and the staff that make up clinics. So let's realize that we're really orchestra leaders. Everybody's going to play a different instrument. And my job is to get them playing in concert with each other. You know, to play a wrong note's okay, but you can't do it often. And so, and then share that message. When you whiteboard that, what do you guys all want out of this individually? Then how do we put it together like a great orchestra conductor and realize that some of you are made as an axe and some of you are made as a razor blade, but we complement each other to build success. But what we're faced with, them all coming from different cultures, they're all coming from different educational levels as even physicians. And so reaching a compromise, unless you're speaking into them deliberately in front of them, asking them and talking to them, if it's my plan, it's never going to work. And it doesn't mean my ideas aren't good, but my plan has to become their adopted plan with checkpoints to say this is working and this isn't working. And that's what collaboration is. And that's what the career has taught me. So surround yourself with better people than you are. When I say better people, people that are smarter than me. I want smart people around me. And then I just want to be the conductor and have a written plan that people are willing to buy in and understand that we're so uniquely different. We're different in our culture, our religion, our faiths, our males, how we practice medicine, the cars we drive. And let's try to put it all together. Despite what we, for the last 4 years, 8 years in the country, where we live in a really division type organization. And sometimes we let that parrot into our own being and we bring it into the workplace. And my job is to separate that and say, wait a second, this is a free zone. And our job is to physician groups break up over economics and over personality differences. And I think one of my skill sets that God gave me was the ability to speak into physicians and to speak peace and organizational skills, because without that, it's just a constant fight. And so as a leader that's leading an organization, take a deep breath. Realize you're really just a conductor of a huge orchestra or a band, anything you want it to be. Imagine that and ask them, sit down with them and say, hey, we're going to break bread. What do we all want to achieve? And come out with common goals. Be flexible enough to change them if you need to change in changing times. It was interesting. I was actually having to have my first dental implant in town in Lakewood Ranch not long ago. I'll leave the people unnamed. And so it was my day to have the tooth extracted, right? Never have had this before, but I cracked it from grinding my teeth and it damaged the tooth. So I'm in a major orthodontic offices and they closed the door, and instead of doing surgery, the providers came around and said, we know, this is what they said, we know that you're in the healthcare business, mergers and acquisitions. We need some help. Senior doc wants to sell on. He's got millions of dollars of offer, but we're employed here. We're not really wanting to do this. So the next hour, instead of having dental work done, was spent talking about mergers and acquisitions. And so it's everywhere in the healthcare space. And I shared with them, and I sent them many articles. It's neither good nor bad. But I said, imagine this. He has a chance. He's worked for 45 years to take millions of dollars off the table. He's going to share some of it with you. But if he doesn't take it off the table, it's gone forever. What would you do if you were him? And their answer was, well, we're not him. I understand that. And so it is in leading. If you're really hiring people, they're different age groups, different thought process, different marriages, different goals, different socioeconomic statuses, different debt levels. And sometimes it's just about a paycheck for them. Well, we can't be running a company that's just about a paycheck. We have to have a mission. We have to have goals. We have to have truth, trust, and communication. So be a band director. That's my story.
I cannot think of a better way to bring this show to a close. That is a brilliant message. And Doug, I want to thank you for joining us on the Healthcare CEO.
Thanks, Daniel. Thanks, Daniel, for having me. Have a great day.
Thank you for joining us on the Healthcare CEO Show. If you've enjoyed this episode, don't forget to subscribe on your favorite podcast platform for more insights from the top. Until next time, lead boldly and care deeply. See you on the next episode.